your in-laws at some point. You can be like, I have this really, really important quiz to do, and then go pretend to do it, or just look at it a little bit. So it's up there. I know time gets crunched at the end. I would like to remind you that it doesn't have to feel that way, because you can look ahead on the lectures, right? You can watch them before we actually have it. And then if you did that, when we got the last bit of material on Tuesday, before you have the test over it on Thursday, you wouldn't have felt as overwhelmed. Does that make sense? So you can kind of get ahead, watch the lectures, read the notes and everything. So if you end up being overwhelmed at the end, it's your own fault. That's what I'm saying. Okay, and then the other thing is that there's going to be a couple of bonus opportunities. One of them you already know about. That one's just for the final. So if you don't have to take the final, you don't need to do it. And it's been up all semester long. It's the liver list. Do a crappy job, I will give you fewer points. Do a comprehensive job, I will give you all the points, because you all have the same information, and you can search a PDF for the word liver just as well as I can and organize it into a categorized list. You can totally do that, right? And all your lab stuff and all your lecture stuff is searchable and cut and pastable. And then all you have to really do is take the time to organize it into body system and functionality, right? Go ahead.
When is that due?
When you take your final.
Okay.
Yes, you will give it to me when you take your final. And then there will be another bonus opportunity that I'll probably post for you guys the week after Thanksgiving. It's easy, but it is 20 questions that are like how we evaluate from semester to semester how our students are doing comparing one lecture professor to the other one. So that'll be for bonus, and then I'll have a couple of survey questions at the end. Ask a little bit about how you studied, some feedback about lab, because they're doing some changes. Some of them are working, some of them aren't. I'd like to know. And then you'll get bonus points for doing that too. And that won't go on your final, it'll go on one of your tests. So, cool? Okay. All right, so we are going to finish this set of notes and start the next one. So what we were talking about before your test, and it's been a while, was we were talking about hemostasis. Somebody define that term for me. What is it? Hemostasis. Yeah, so it's stabilizing blood. It includes clotting, but it is not limited to clotting. And it's basically 5 stages. The first stage is vasoconstriction that occurs upstream of the damage, right? Then the next stage is platelet plug congregation, right? Platelet plug formation, when they start to blob up in the hole. And then the third stage was the complicated one, and the complicated one was coagulation, yes? And so it gets really complicated, but I do have this figure for you, which I haven't posted for you yet. But I just want to go through this really quickly. And then you're going to have this both on your quiz and on your test. I'll just delete some of the red words, right? But it's actually just sort of a visual overview of what we already talked about. So let's look at it. And it's just got, instead of every single clotting factor, it's just got the important ones. So tissue damage, without even looking, would start what pathway? The extrinsic pathway. That's how the extrinsic one starts, right? And of course, we know we need calcium, we need some other things, but ultimately what we get is tissue factor that gets to factor 10, activated to factor 10A, which is prothrombinase. So this starts the common pathway, right? So the big picture here is exactly what you learned before. Tissue damage will cause activation of the extrinsic pathway. The true trigger in the extrinsic pathway that is unique is tissue factor 3, or TF3, right? And TF3 will get you to the common pathway, which is when you get to prothrombinase, right? So that's all the important portions right here. And then the intrinsic pathway doesn't start with tissue damage. It starts with these activated platelets, those sticky platelets, right? And that's called the intrinsic pathway. And the important player there is platelet factor 3, not tissue factor, but platelet factor 3. And you got a whole bunch of other stuff that's involved, which will get you to factor 10A, which is prothrombinase, right? After you're at prothrombinase, you're at the common pathway. Yes? And the common pathway, prothrombinase converts prothrombin to thrombin. Yes? Thrombin converts fibrinogen to fibrin. Fibrin is what is stabilized to form the clot, right? So this is just a visual representation, an even simpler, more visual way of looking at the same thing. So I'll post this picture for you, and there's also a quiz about it, and then I'll blank out one of the important terms on a test, or more than one, and then you'll fill that in and you'll answer other questions. So I want you to hold on to important, relevant details of blood clotting and the big picture. I don't care if you memorize every single factor for me. You might have to do that in another class, but that's for another class, okay? So if it's in your notes, if it's on this figure, if it's red, it's important, yeah? Okay? And then, that's coagulation. And now all we have to do is the last two stages, and the last two stages are short. It's easy. So the next stage, after you have clotted effectively and you're no longer leaking fluid, this is called clot retraction. And clot retraction is, interestingly, they figured out that platelets have actin and myosin in them, and they do a little bit of cross-bridge cycling when you are no longer bleeding. So when they get the trigger that says, hey, the hole is plugged, let's retract the clot, what they do is the platelets are all kind of stuck in to the clot. They start to pull, and it ends up pulling the edges of the wound closer together, right? You've probably experienced that if you've ever had a road rash, right? And you pushed out the serum, right? So clot retraction is the next phase. What gets pushed out when a clot retracts is called serum, and it's pretty much blood plasma minus the clotting factors, right? Because they stay in the clot. Cool? So that one's pretty easy. And then the very last one is not hard. It initially looks hard, but it's not. So remind me what the clot was made of. What protein again? Fibrin. So the last stage is fibrinolysis, because now I'm done and I need to get rid of the fibrin, right? And I need to let the blood flow freely again. So fibrinolysis. So it was made of fibrin. So what happens is healing tissues, formerly damaged and now healing tissues, release something called TPA. And it's tissue plasminogen activator. What TPA does is converts plasminogen, as in the genesis, to plasmin. And this is pretty easy because what does plasmin do? Plasmin dissolves fibrin. Good? And you dissolve clot. Those are really little cascade. Somebody remind me why TPA is released again? Why would it be released? Yeah, because you're healed, right? The healed tissues will release TPA, which is tissue plasminogen activator. Does that make sense? And it dissolves fibrin. So this, we have genetically engineered TPA now. We can make it in the lab. It is a really, really expensive and really, really effective clot buster. It is never used as a maintenance medication to send you home on because you would bleed out. But it is used, for instance, if someone is hospitalized immediately after a stroke and you want to make sure you don't have another stroke, they can administer TPA. They have to be ready to intervene very quickly because if anything occurs, you will bleed out like crazy. It's also outrageously expensive. So if you do not have good insurance and you had a stroke, you ain't gonna get it. And ain't that something that we should discuss as a population? Ain't it? Right? Remember that as you vote in the future. Okay, so that's the last of it. So all we have to do now is talk about clotting considerations. Like, so since clotting starts with this little positive feedback loop, and of the platelet plug, here's my question to you. What is it that prevents a clot from starting in one location and just continuing to fill up the entire vessel? Why does it end up staying local? Well, we know that with the platelet plug, the healthy tissues are saying move along, right? But with the clot, there are also some things that are occurring that say don't get bigger than necessary. So what happens is, first off, blood circulation is constantly carrying away the clotting factors. And in addition, fibrin, as it starts to grow, actually inactivates thrombin. So it's got a little negative feedback as it gets big. But then the other thing is that in order to get a clot, you have to have a concentration of activated clotting factors, all of those A's, 10A, 9A, 11A, whatever. But those tend to only accumulate at the site of damage. And then the other thing is that the bloodstream constantly has always activated anticoagulants in it, right? So what has to really happen is the concentration of activated clotting factors has to overwhelm the baseline concentration of anticoagulants. And that generally is limited to the site of injury, except for in situations in which you clot inappropriately, like with atrial fibrillation. And that's just because it's just sitting there and the blood is not really flowing, right? So I'm not getting a whole bunch of anticoagulants. Does that make sense? So the blood's just sitting there and I'm having the opportunity for things to activate. Okay, so what are these anticoagulants? Some of them are plasma proteins like antithrombin, and then there's heparin. Have you guys ever heard of heparin if you've been in medical situations? It's secreted by mast cells and basophils, and it's an anti-clotting factor. It says don't clot. And of course, they use it clinically, right? They used to use it really commonly in IVs, Heplock, because what you want when you have an IV is you want for the blood to not clot over that site so that you can still get adequate blood flow. Now they are more likely to use saline locks unless it's a central line, and then they'll use a Heplock. But in addition, heparin this is what I had to shoot myself up with the whole time I was pregnant to avoid inappropriate clotting because I had atrial fibrillation. And it's a really, really old medication. It doesn't have as many side effects as a lot of them. It's also really cheap. So clotting pretty much only occurs when the concentration of activated coagulants is much higher than the concentration of constant anticoagulants, right? And it does occur. I want you guys to know that clots do occur. But they're anticoagulants, right? So generally speaking, in a healthy person, the clot doesn't just get to sit around and accumulate, it gets broken down by anticoagulants. In a situation like mine, if I go into a long bout of atrial fibrillation, then it's really just sitting there and gathering friends without very much blood flow to keep it going. So stasis of blood is a big problem, right? Okay, so heparin is also administered therapeutically. The other thing that's kind of interesting is, so you know that you can give blood. Why doesn't the blood in the bag immediately clot? Because people are clever and they figured out, oh, wait, let's do this one first. This one is blood banks. People are clever and they figured out that all I have to do is put a chemical into the donated blood that ties up all the calcium ions, and then I can't do extrinsic pathway, intrinsic pathway, or a common pathway. Pretty damn clever, right? It's just a detergent, actually, that is really attracted to the positive calcium ions, pulls them all out of solution. But that's okay, because then if I give the blood back in, your calcium, right, will provide what's necessary. So that's kind of interesting, right? They don't even have to add more calcium back to it. EDTA is what they primarily use. And then let's talk about these. They're consistently referred to as blood thinners, but that's not what they do physiologically. They don't really change the viscosity of your blood so much as they change the likelihood of your blood to clot. And that is Coumadin and Warfarin, like dicumarol is one of the names for it. This is a vitamin K antagonist, but do you remember what vitamin K was necessary to make? It was necessary to make prothrombin. So you can't do the common pathway as well if you don't have very much vitamin K. So they use that not because it thins your blood, but that it makes it less likely that you are going to clot inappropriately. But of course, it also makes it less likely that you'll clot appropriately. So when people are on Coumadin and Warfarin and they run into the coffee table, they're going to have a ginormous bruise, right? They probably won't die because of it. But you also don't want to, I don't know if you know anybody who's on this medication, you probably do, right? You also shouldn't eat things that are really high in vitamin K because it'll completely undo what the medication does, right? Okay. Now, last little tidbit is just to talk about inappropriate clotting. Inappropriate clotting, which is really very problematic, and it's a common complication of heart disease. So thrombosis is the formation of clots inside an unbroken blood vessel, or I suppose even inside a chamber like it occurs in me. A clot, just the fancy word for clot is thrombus, right? And if the clot continues to grow larger, it can grow large enough to block a small vessel. If it was an artery, then the tissues downstream would die. Now, with that in mind, I want you to think about how small your coronary arteries are. Yes? They're really, really small. And how small the arteries in your brain are. I'm not talking about, the internal carotid arteries, but the arteries that are actually supplying circulation to your brain. So those are really small arteries in a tissue that has almost zero anaerobic cellular respiration capacity and is non-regenerative. So that's where it gets to be a big deal. You throw clots to other tissues all the time, but those tissues are regenerative and you might not even know, right? First off, you're less likely to do that at your age than you are, for instance, in your 60s or your 70s. But so most of your thrombi form in the deep veins of your leg because they're low pressure, right? And so if the blood is low pressure, it's not moving as quickly, right? So that's where most of your clots form. But it's not problematic for most of us because they get broken down by anticoagulants and you really didn't know that they occurred. They are more likely to occur if you are inactive because you have less venous return, right, when you're inactive. The more active you are, the better venous return you get. So sitting for long periods of time and those kinds of things will actually do it. So they usually do little damage. But of course, we know enough about circulation to know that a clot that started in your leg will end up back in your heart. And then it gets pumped from your heart to your lungs, which could cause a pulmonary embolism if it gets caught in there. If it makes it back from your lungs to your heart again, it could get pumped to your heart, right, through the coronary arteries, causing a myocardial infarction, or could get pumped to your brain, right, causing a stroke or a cerebrovascular accident. So it doesn't have to have originated in those places. That's just where it ends up blocking blood flow. So if the clot breaks loose and begins to float, it's called an embolus. There are other reasons that you could have an embolism, like a gas bubble or something when you were diving, but we're talking specifically about clots here. So causes of inappropriate clotting. What are the things that increase your likelihood of thrombosis? So let's talk about those briefly. Anything that makes the inner walls of your vessels lumpy makes it more likely that you're going to catch a platelet and it's going to start inviting its friends over. Yeah? Okay. So those things are arteriosclerosis and atherosclerosis, because when you gunk up the cholesterol in the wall, it doesn't go nice and smooth. It's lumpy on the wall. Okay. And then the other things are IV drug users. I'm not even talking about illicit drugs. Just if you have the need for whatever purpose to poke holes in your vessels frequently, then you are going to scar your vessels and make them lumpy. Okay, that's one of the risks long term of being an IV drug user, but definitely not the only one, right? Okay, some IV drugs are absolutely necessary, so I'm not necessarily even saying it's injecting heroin. Any infection, hypertension. So hypertension and its relationship to thrombosis is, first off, you are stretching and scarring your vessels and you're making them lumpy. You're making it more likely that they're going to catch a platelet, right? Infection resulting in scarring. If you have a patient who is immobilized, one of the many ways that they are at risk is clots. So one of the many reasons that you should exercise them and turn them and move them and massage them is because you are trying to decrease the likelihood of forming clots inappropriately. And then sitting too long. Like they just did the first plane ride from where to where was it? Where was it? It was from somewhere to Sydney. Yeah. And it was like a 17-hour plane ride. Oh my God. We did Japan recently, and I was like, I never want to see any of these people ever again. So that is primarily because of the blood clots that can form in your legs. So you're supposed to get up and wiggle when you're on the plane, and it's not because they care about your health, it's because they don't want you to sue them. And then I put a question mark on this because the data isn't super strong, but it's suggestive, and it's something that you could do that would be protective without compromising really anything. So we do think that it's oxidized cholesterol that actually sticks. So if you have a diet that is rich in antioxidants, you might be able to get away with more cholesterol in your diet. We don't know how impactful this is, but y'all know that you need antioxidants for other crap anyway, so let's just go ahead and acknowledge that this might be another benefit. Vitamin C, vitamin E, beta-carotene, selenium, all of those are antioxidants. So oxidized LDL sticks. If it can't get oxidized, it isn't as sticky. So worth mentioning anyway. Smoking is a risk factor for thrombosis because it raises your blood pressure. It also somehow decreases the amount of vitamin C that you absorb, and we don't understand that quite yet. So it actually zaps some of the antioxidants from your system. And I will tell you, as someone who's dissected a lot of cadavers, that when I dissect a cadaver of a smoker, their lungs, it may not be detectable in their lungs, but every single one of them has arteriosclerosis. Like squeezing toothpaste out of a tube amounts of vessels in their, amounts of fat in their vessel. It is just mind-blowing how much fat is in the vessel of a smoker. It just completely sticks onto the walls, even if they're not obese. It's the weirdest thing. So like when I know that they're a smoker, the first damn thing I want to do is cut open their femoral artery. I'm like, I want to see this. And it's like, squirt. I'm like, don't think I haven't showed my kid that. I already have. I'll be like, I got something to show you. I'm going to videotape it for you. I'll cover up the face. I'm going to show you. How did I know this person smoked? Squirt. And then the other thing, and this is important for women, it's important for women when they're pregnant to understand that high levels of estrogen tends to make your platelets stickier than they otherwise would be. So during pregnancy, you need to be careful about compounding any other clotting factors, right? So for instance, you'd like to keep your blood pressure as low as possible, so you don't add that. You don't smoke during pregnancy. This is one of the 27,000 reasons that you don't smoke during pregnancy. You try to keep all of the other factors that you can control controlled, because high levels of estrogen increase your likelihood of inappropriate clotting. Or in the old days, when birth control pills, hormonal contraception was really high estrogen level, they also had an increased risk of heart attack and stroke. And now it's very, very minor because they've reduced the level of estrogen. It's still slightly more than it would be if you were not on oral contraception. So for instance, if you have a really, really responsible physician, before they give you a hormonal contraceptive, they'll ask you if you're a smoker, because you shouldn't combine those two things. The combination is negative. Okay, and then I put a couple things for you. This one is actually really helpful. This dude, Armando Hasundungan, I wish he would tell me how to say his name. He is both a physiologist and a physician, and he does these real-time whiteboard things in which he draws it. It's not the only cool one. So he draws the whole hemostasis coagulation thing real-time, and then it's like got a picture afterward. So go ahead and try him, and he's really good for other stuff. If you guys are taking patho, he does tons of good patho stuff in the future. Okay, and then we are going to move on to the urinary system. Okay, so I will tell you, and I know you've been busy, that you're going to have a harder time with urinary system if you don't remember the anatomy. Yeah? So if you haven't brushed up, especially on, for instance, your nephron anatomy, you will want to do that before you come to class again, okay? Because the P depends upon the A here, right? I think I try to tell my anatomy students that really the two body systems that I think that holding on to the anatomy counts the most in is cardiovascular and urinary. That's what I think. What do you guys think? Any other body system in which the physiology really like depends on you being able to recall the anatomy? Because it's not like anybody ever asks you freaking the medial malleolus in physiology. They're like, I don't even, physiologists don't even care what that's called. They're like, whatever. So there's a before you begin section. It's pretty long. Make sure that you can do it. Cool. That's all anatomy review. And then I gave you a nephron to label. If I were you, I would color code it. Here is the common thing that happens in both anatomy and physiology students. You don't remember which ones are blood tubes and which ones are pee tubes. Okay? So I would color code it and draw everything in there that is blood, red, and everything in there that is pee, yellow. And then don't accidentally end up in the urine when you meant to stay in the blood, or accidentally end up in the blood when you meant to stay in the urine. So keeping track of the fact that there's two sort of almost parallel, and not exactly parallel, tubes, but then you exchange things between them. So let's talk about the big picture understanding before we get into the details. So when you're doing urinary system physiology, basically what we are going to be talking about is these 3+1 functions. Oh, that's what I did with it. Put it over there because I wanted to get back in, and then I heard, where the hell is it? Who did that? Oh, me. That's who did it. Okay, so I start the same way in anatomy when I talk about this, but we need to make sure that we use these terms appropriately, especially for phys. Okay, so basically what we are going to do is at the nephron. Let me get a nephron up for you guys to look at. Here's a nephron. Big picture understanding, because some of you guys, it's been a minute since you had anatomy. Some of you guys are lab aides, so I expect you to kick ass on this, okay? So what we have is, at the kidney, we have over 1 million nephrons per kidney. What nephrons are is the site at which you have microscopic blood tubes, capillaries, next to microscopic pee tubes, called the renal tubule, right? Okay? And you put them close enough that they can exchange, but you never hook them together, because we don't want urine circulating into our cardiovascular system. What we want is we want them snuggled enough that I could do transport from one to the other, right? So that is what's going to happen at every single nephron. So conceptually, before we get any further, that means that, of course, the blood going in the renal artery is different than the blood going out the renal vein. Yes? It's going to be lower in volume, of course, but it's also going to be specifically changed in composition, right? And so what is going to happen at the nephron is we are going to do 3 processes, and we're going to understand some details about these 3 processes right now. So basically what we are going to have is we're going to oversimplify how this phys works, and we're going to say that we have 2 sets of tubes that contain fluid. This one contains blood, and this one contains urine. It's actually not called urine until it hits the collecting duct. It's called filtrate before it hits the collecting duct, but let's just oversimplify it for a second, okay? And of course, we know that blood is circulatory, goes in, goes back out, renal artery, renal vein, yes? But urine is not circulatory. It starts in the kidneys and ends up in the toilet. Yes? So whatever you actually get rid of is going to be excretion. With me? Yeah? Okay. But in order to do the excretion, I'm going to do a 3-step process. And the 3-step process is going to be exchanging between these 2 fluids. Both of the tubes are porous. The capillary is fenestrated. Most of the tube is simple and has lots of transport capacities on it. So they don't provide a big impediment to transport between them. This is simple squamous epithelium. This is simple cuboidal epithelium. Okay? So no big impediment to transport. So we're going to have 3 processes. So the metaphor that I always use for this is that your kidneys treat cleansing your blood like cleaning a hoarder house. Not a whorehouse. That's a different thing. Hoarder house. Okay? A hoarder house. So what we have is we have so much crap in the house that the very first step is just to get everything that will fit through the door out on the lawn. Both grandma's china, 72 cat boxes full of poop, 150 cans of cream corn, 800 rolls of toilet paper, even though you're 80 years old and you ain't going to use 800 rolls of toilet paper, okay? So what we are going to do is this first big dumping step is going to be non-specific, just anything that will fit through the holes, the doors. And it's going to be called filtration. And you know, filtration is pressure driven, yes? And which of these fluids is higher pressure? Yeah, so filtration moves things that direction. Make sense? Okay, what kinds of things? Well, just to be really simple about it, whole bunch of water, because filtration always moves water. And pretty much anything else that will fit through the holes, non-specifically, including, of course, ions, because those are small, yeah, and water-soluble. And nutrients, including stuff that I really, really like glucose and amino acids, right? And waste products that are water-soluble, like urea, uric acid, ammonia, okay? So I'm really, really general about what I dump out, because I was just doing the initial dump. But now what I'm going to have to do is I'm going to have to start being thoughtful about what moves now, okay? So now I got the house kind of one big sweep. I wasn't super specific, didn't open every cabinet or anything, but I got all the stuff out. And now what I'm going to do is start to select what I bring back into the house, yes? And that process is going to be called reabsorption. Which direction is it going to move things? That direction. Okay, so what do you think, just conceptually? I am going to have to, I'll go ahead and tell you this, that I have to reabsorb water. All of these things are moving through water, okay? And then I am going to reabsorb, how much glucose and amino acids do you think I want to reabsorb on a good day? Yeah, right? And most of the time you can absorb all of them. There are limitations. They're subject to carrying capacity, or saturation, sorry. How about ions? How about as needed, right? So if I was calcium deficient, all of the calcium that I put out on the lawn, I bring back into the house. If I had just had 2 milkshakes, I can probably leave some of it out there, right? Okay. If I had eaten a whole bag of chips, I can leave all the sodium out there, right? But if I was on a freaking detox fast because I didn't take physiology, then I would probably need to bring that back in. So ions, let's just say as needed. Waste products. What do you think the general rule is for waste products? Leave them out there. There is an exception to that because there's one of them that's involved in regulating pH, but we won't get into it too much in this class. So leave them out there with a little asterisk. If you ever see anything about urea being reabsorbed, got kind of a corollary function that's going on, but you don't reabsorb most waste products. And then the last step is to be selective about the house this time. So this time go through and open every single cabinet, look in that basement bathroom because there's 200 more cans of corn in there, right? Look under all the beds, found 3 more cat boxes, right? And now what we are going to do is we are going to do this step, which is secretion. Which direction is it going to move things? Yeah, but it's selective, so it's different. This was just dumping, right? This is selectively bringing back in, and then this is selectively going through the house one last time. So what you're primarily going to do with secretion is get rid of any waste that you didn't catch before, yeah? And how about any excesses? If I still had too much potassium, or too much sodium, or too much whatever, I get rid of it there. But that's selective. Does that make sense? So by the time you get finished, what happens is you will have preferentially put whatever you wanted into the urine, and you will have selected what goes back into circulation, right? So of course, the blood that goes back into circulation is going to be lower volume and different composition. Hopefully, on a good day, it'll have the same composition of nutrients, right? Can't always do that, but not necessarily the same composition of ions, right? And you will have lost some water. Everybody okay with that? So here's the issue. I'm going to go ahead and tell you guys now. Sometimes I filter, reabsorb, and secrete the same thing. So when I, for instance, I'm talking about sodium filtration, I'm being specific about pressure-driven movement of sodium. If I talk about sodium reabsorption, I'm talking about selective movement of sodium that way. And if I talk about sodium secretion, which doesn't happen very often, but could, I'm talking about moving it that way. So you have to use the words specifically. You can't use them interchangeably, right? Okay, does that make sense? Okay, so that's the biggest mistake that people make on that test is just not learning to use the word that they mean, right? Okay, so let's go ahead and get started with the kidney specifically and what it's actually going to do. So by these processes, by the way, the equation is simply this. Excretion equals filtration minus reabsorption plus secretion. Yeah, that's all it is. Okay, so by doing these things, guys, don't you end up regulating the water concentration or osmolarity of the blood plasma? Yeah? Yeah. You also end up regulating the ion composition of the blood plasma. You end up regulating the volume and therefore the blood pressure, right, by doing this. And of course, you do what we've known since, like, I don't know, 3rd grade that your kidneys do, which is get rid of waste products. Interestingly, in physiology, we spend far less time talking about this than we talk about anything else. We're like, yeah, it removes waste products. That's like the easy part. So urea, uric acid, creatinine, other water-soluble, mostly nitrogenous, but not exclusively, waste products. And then your kidneys do remove some foreign chemicals. Some drugs are actually removed from the body via the kidneys. Some are detoxified in the liver. It kind of depends. You need to be careful about that. I'll bet Jen knows this. There are some drugs that if you have kidney issues, you can't take these over-the-counter medications. There are other drugs that if you have liver issues, you can't take these over-the-counter medications, right? So some drugs, some pesticides, some food additives are hard on the kidneys. And then the kidney has a couple of other functions. These two we already know. The kidney makes 2 hormones, EPO and renin. Okay, I'm going to ask you, ready? EPO is made in response to low blank. What? Not blood pressure. Low oxygen. And renin is made in response to low blood pressure. Exactly. So these two are both all up in regulating cardiovascular function. Yeah? And then the kidney, believe it or not, I don't know why that has a big space there. The kidney, believe it or not, can also help with gluconeogenesis. Gluconeogenesis is mostly a liver thing, but in situations like starvation, the kidney actually can do a little bit of gluconeogenesis as well. And then the kidney also has to activate one of your forms of vitamin D3, which is necessary for calcium absorption. Okay, so now let's get into the specifics of these 3. Okay, so I think we can do a think, pair, share. Let's try it. I'm not quite sure if you guys are ready for this one yet, but we'll give it a shot. Oh, yeah, no, you should be able to do this. Okay, some hormones that you already learned and you predicting how they might impact urine produced. So think this through, and then we'll go through it. If you remember your hormones and some anatomy, you should be able to do it. That was outside. That wasn't in the class. Is that 6 more people? There we go. Okay. So let's get into each of these. Filtration always goes first because you don't have anything to reabsorb from unless you've done filtration. It goes both first anatomically and it has to go first physiologically, right? Because you don't actually have any filtrate until you do filtration. So let's look back at the anatomy to remind you where filtration actually occurs. So filtration really occurs at the glomerulus. So from the glomerulus to the glomerular capsule, also called Bowman's capsule. Okay, so here's what it looks like way up close. Okay, so let's make sure that you can sort of identify what you're looking at here. Collectively, the pitcher and the catcher on filtration are called the renal corpuscle. Does that sound vaguely familiar? And it includes both the capillary ball called the glomerulus, yes, that's the anatomy we're talking about, and the capsule, which is either called the renal capsule or Bowman's capsule. Phys textbooks still use eponyms, anatomy books don't. But what I want you to see is what you're actually looking at. What you're looking at here is you're not actually seeing the capillary in this picture because the way that the capsule wraps around is, imagine that the capillary ball, the glomerulus is like this. What happens is the capsule is double layered. So if I imagine sticking my hand into a softly blown up balloon, I'm going to get a layer of the capsule here, yeah, and then a space, and then another layer of the capsule. So that's why it looks weird, because of those podocyte cells. You're actually looking at the visceral layer of Bowman's capsule, and then this is the parietal layer of Bowman's capsule. Okay, so let's look at it a little more closely. And what you actually see is the capillary is fenestrated, so it's really porous, right? And in addition, the podocytes have these filtration slits, so again, it's really porous. There are over 1 million per kidney, so there's lots of surface area. And then it's super duper thin, the layer between them. So this location where you're going to do filtration is called the filtration membrane. This is going to be high pressure, this is going to be low pressure. There's no connective tissue in here, just a basement membrane. So hardly any impediment to filtrations going on there. Does that make sense? And then there's one other little tweak, not really shown very well in this picture, that makes these glomeruli so good at filtration. And that is this little tweak. Not super easy to see, but the afferent arteriole has a larger diameter than the efferent arteriole. What does that do to the pressure in between? Increases it. So, and it does it for every single one of the over 1 million glomeruli per kidney, right? And so what that is going to do is cause massive amounts of filtration. Surface area, pressure, and porosity is going to cause massive amounts of filtration. So we've already got this equation going right here. So the first phase of kidney function is glomerular filtration. Okay, so glomerular filtration is going to move substances from the blood to the filtrator urine, right? Does that make sense? Okay, and so filtration is only pressure driven, and what's going to happen is the filtrate is going to contain everything that was in the blood that would fit through the holes. Okay, on a good day, that should not include red blood cells or white blood cells or huge proteins. But can you see, just theoretically, what chronic untreated hypertension can do to kidney filtration? What could you end up with in your blood, in your urine, if you had chronic untreated hypertension? Yeah, you can end up with blood in your urine. It can be the cause of kidney failure. Yes? It can just bust through those holes. So filtration occurs in the renal corpuscle, which is the glomerulus plus the capsule, and the filtration membrane is what we were talking about right there. So they call this the filtration membrane right here. And the filtration membrane is really thin. It's got the endothelium or simple squamous epithelium of the glomerulus, and it's got the visceral layer of Bowman's capsule with the podocyte cells, and just a basement membrane in between them. So let's talk about how much you filter. Okay, it is impressive as hell, because both kidneys in a typical average anatomical normal physiological person will filter out 125 mils per minute, or about 47 gallons a day. That is amazing. The rest of your capillaries combined only filter out about a gallon a day. Okay, now we also, of course, do not pee 47 gallons per day, even if you're one of those irritating people that has to pee every 20 minutes and nobody wants to take road trips with you, right? Because we do a boatload of reabsorption. So generally speaking, you pee around 1 liter a day. It's usually about as much as most people pee. So, but we're talking about filtration right now. So what I want to talk about is GFR, which is glomerular filtration rate. Glomerular filtration rate is the amount of filtrate that is flowing out of all of your renal corpuscles in both kidneys every minute. and it is about 125 mils per minute. There's variability, right? Depending on how much you've had to drink, how much you haven't. Collectively, all of the other capillaries only do about a gallon. This does 47 gallons per day. So let's talk about the factors that are impacting GFR. First off, the most logical factor that's going to impact GFR is just going to be blood pressure, right? Right? Does it make sense to you that your blood pressure will be directly correlated to your GFR? Yeah? Higher blood pressure, higher GFR, lower blood pressure, lower GFR. But there are tweaks that you can make to it as well. Okay, so let's talk about the tweaks. So first, we're going to talk about intrinsic regulation of GFR. Intrinsic will involve paracrine agents. It's going to be local. It's not going to be massively powerful, yeah? But it's easy to understand. Okay, so if I told you that the tube can actually talk to the glomerulus and to decide whether there's too much urine being made. This is called, listen, tubuloglomerular feedback. Okay, so what happens is if the macula densa cells in the distal convoluted tubule, because that's at the end of the actual tubular component of the nephron, if they detect boatloads of flow going by them, what they can do is release paracrine agents that will, you choose, don't look, cause vasoconstriction or vasodilation of the afferent arteriole. Vasoconstriction, yeah? Because if you vasoconstrict the afferent arteriole, you will decrease filtration, right? So this is tubuloglomerular feedback. Make sense? It's pretty logical, isn't it? Okay. It's just paracrine, so it's not that powerful. It can't make huge changes in GFR, okay? And then we are going to have another paracrine one, but this one is, instead of monitoring the distal convoluted tubule, it's going to be monitoring the blood itself. And again, this is paracrine. So this is called biogenic regulation, and biogenic regulation says, I want constant GFR despite changes in, for instance, body position. So do I really want, every single time I walk to my car, when my blood pressure increases just a little bit, right, do I want to actually produce more pee? Do I want to produce way less pee when I'm laying down? No, not really, right? What I would like to have is a relatively constant rate of GFR so that my blood is getting cleansed relatively constantly. So what can happen is you can tweak the afferent arteriole when your blood pressure goes up and down to keep your GFR constant. That's what we're trying to do here. We're trying to get a relatively constant GFR despite slight changes in body position and blood pressure. That make sense? Okay, so this is going to kind of do what you expect it to do. So what is going to happen is we've got stretch-sensitive cells in the afferent and efferent arteriole. And what this is going to do is, if I get up and walk around and my systemic blood pressure increases, what should I do to my afferent arteriole to keep my GFR constant? Constrict, yeah? If I am laying down and my blood pressure decreases, what should I do to keep my GFR constant? Dilate, exactly. So it's really simple, right? It's just these little bitty tweaks that you can do, right? Does that make sense to you guys? Okay, so the only difference between this one and this one is this is monitoring the urine to figure out what to do with the afferent arteriole, and this is monitoring the blood to figure out what to do with the afferent arteriole. Is that good? Okay, all right. And then the extrinsic control of GFR is primarily just by controlling blood pressure. So anything that you do that controls blood pressure will control GFR, right? Does that make sense? So do we have to go through all the stuff that controls blood pressure again? Because I don't think we do. Because we did like a whole chapter on it, okay? So because blood pressure impacts GFR, any nervous or endocrine change that impacts blood pressure can impact GFR. So you should review all of that before your final at some point, okay? So the only exception is this little tweak, this little weird nervous system exception, which I kind of think is cool. Sympathetic activity, of course, overall increases your blood pressure, yes? Okay. But mild sympathetic activity actually doesn't increase your GFR, which kind of makes sense to me because if there's a tiger and a tiger's chasing me, I don't really have time to pee, okay? So what happens, even though it's sort of counterintuitive, is that sympathetic activity is the one sort of blood pressure increaser that doesn't also increase GFR, primarily because sympathetic activity while it's doing constriction everywhere and increasing systemic blood pressure, it also does constriction of the afferent and the efferent arterioles. So you can pee when the tiger is gone, right? That makes sense? Good. And then let's talk about circulatory system shock again with reference to this. Okay, so although it's counterintuitive, let's say one more time, mild sympathetic activity actually decreases GFR, even though it increases blood pressure, because it actually tweaks those afferent and efferent arterioles. So let's go back to talking about shock and talking about treating shock and all of this. So we know that circulatory system shock is when your blood pressure is too low to deliver adequate blood flow to capillary beds. Could be from hemorrhaging or dehydration or myocardial infarction or whatever the hell it's from. And therefore, it causes really low glomerular blood pressure, right? Does that make sense? So if you're in shock, one of the nasty things that could occur, even if you don't die, is if your average mean arterial pressure goes really low, like below 45 millimeters of mercury, no filtration occurs. You are not generating any pee. It's called renal suppression. And the intrinsic mechanisms that we talked about, they can't help with pressures that low. Like little tweaks of the afferent and efferent arteriole can't do much to that. So this is called renal suppression. It'll damage your nephrons if it's long-term, and of course it results in anuria, which is no urine production. So if they do anything in the hospital to you that could have impacted your kidney function, or you did something to yourself that could have impacted your kidney function, what they do is they make you pee in a cup so they can measure how much urine you're producing, because it's a good indication that your kidneys are functioning, okay? So now, would I treat this person who had circulatory system shock and also anuria with epi, which is what I would usually use for circulatory system shock? It wouldn't be indicated in this situation, right? Because it would add to the problem of renal suppression. So if you've got a kidney patient who also has circulatory system shock, what you want is you want to treat them with something that would bump up their blood pressure but still allow for GFR, right? And that is actually dopamine. Dopamine is not as massive a blood pressure increaser as epi, but it does increase your blood pressure. But it actually doesn't have any receptors on the afferent and the efferent arteriole, so it actually allows for your kidneys to function as well. So that's kind of cool, right? Do you remember that the sympathetic nervous system releases epi, norepi, and dopamine? Yeah, dopamine you just don't talk about very much because epi is so much more effective, but in this situation, dopamine is what you would want to use. Okay, so that was GFR, and really the picture with GFR is big picture is pressure is directly correlated to GFR, with the exception of the little tweak of the sympathetic nervous system. And then, of course, you've got two intrinsic ways to regulate it. We can go tube to glomerulus, right? Or we can go blood to afferent and efferent arterial. Does that make sense? Okay, so that's okay, right? Everybody good with that? Okay, so the next phase is where it gets kind of complicated. And this is called tubular reabsorption. So now I want to talk about what's going to go on with the tube. Okay, so when we do tubular reabsorption, okay, we are going to do reabsorption of different things in different places. Okay, so let's just like get a big picture understanding. So before we get into the details, I want you to know that when we are doing reabsorption, you guys tell me I'm moving stuff from what fluid to what fluid? Filtrate back to the blood, right? And I'm selective about it, yes? I'm pulling things back in. So expect for instance, carriers to be involved. If you have to do active transport, you'll do it, but you're being selective. I'm not just letting things move down their concentration gradient. Okay, so this is a general overview, just to get you started. Generally speaking, you are going to do boatloads of reabsorption of ions right here. Don't have very much control over it. You're primarily going to do water reabsorption here, okay? That is hormonally controlled. And then you're going to do last-ditch selective reabsorption here, and that is going to be hormonally controlled. So general reabsorption, mostly ions, other stuff too. Water reabsorption, more selective reabsorption. Does that make sense? Okay, got it? Okay, and in all of those situations, what I'm doing is moving things that I dumped out on the lawn back into the house. Okay, ready? Okay, so are you really? You looked confused. Got it? No? Okay, so let me use the words. Sort of general reabsorption of a bunch of different stuff, proximal convoluted tubule. Water reabsorption, loop. More selective reabsorption, distal convoluted tubule. Good? Okay, and it's going to be hormones that you learned before. We're just going to put them into context of these structures now. Okay, so tubular reabsorption. And so reabsorption moves stuff, you said, from what fluid to what fluid? Filtrate back to blood. Good. Your normal GFR is 47 gallons or 180 liters per day, but your reabsorption is 178 to 179 liters per day. So we are doing a boatload of reabsorption. Oh, I mean to bring this table up for you. Hold on just a second. Wait right there. Chapter is this 18? 1891. Okay, so just to give you an idea, not that you're responsible for these numbers, of how much I filter out versus how much I reabsorb and the approximate percentages. I reabsorb around 99% of the water that I filter out. I reabsorb on a good day 100% of the glucose that I filter out. Urea, again, is reabsorbed in a kind of surprising way because it's got some other functionalities. 99% of the sodium, I always lose potassium. Other things, I almost get all of it back in. So I'm doing a lot of reabsorption. So the water and the solutes are going to move out of the tubule into the peritubular capillaries or into the vasa recta. But the reabsorption is controlled by the cells in the wall, these cells that I am actually going to introduce you to again. So what I am doing when I'm doing reabsorption is I'm going from the lumen of the tube, wherever I am in the tube, okay? And I'm going across these cells. Does anybody remember, I think I mentioned it to you just a minute ago, what kind of tissue kidney tubules are made of? Simple cuboidal epithelium. Yes, it's simple cuboidal epithelium, and the simple cuboidal epithelium has lots of transport mechanisms on it, right? It's got carriers and channels and active transport mechanisms and all of those kinds of things on it. So what I'm going to do is I'm going to move from the lumen of the tube across this epithelial membrane by the cheapest, fastest way that I can, right, into the interstitial fluid, and then I move passively into the fenestrated capillaries. So this will circle around back to the crap that we learned at the beginning of the semester, okay? So it's going to be the same thing that we kind of learned at the beginning of the semester. So reabsorption is going to move, it's basically transepithelial transport, right? It's going to move across the epithelium, okay? And basically what I'm going to do is I'm going to move specific amounts based on the body's needs of certain substances across. Reabsorption will be free if you can get it that way, cheap if that's the next thing, and you will pay straight for it if it's necessary, right? So we would always do passive before active, and we would always do which one, secondary or primary first. Secondary is cheaper than primary, right? And there's really no appreciable amount of endo or exocytosis that goes on at the kidneys, okay? So what we're going to do is we're going to look at concentration gradients and sizes and figure out how the things are moved. And it's going to be the same transport mechanisms you learned before, just put in a new location, okay? So first thing that we are going to talk about is going to be glucose reabsorption. Because, of course, glucose is money, yeah? So how much glucose do you want to reabsorb? All of it, if you can. Son of a biscuit. Okay, so normally, except on the day after Halloween, or if you're a diabetic, right? Or let's be honest, the day after Thanksgiving, because if there are 4 pies, how many do you have to try? You have to try 4 pies. It's like a rule. It's rude not to, honestly. Okay, so glucose reabsorption. So what is going to happen is glucose is going to be reabsorbed by the cheapest, fastest way I can get glucose in, which is going to be secondary active transport. And that's going to be fine because I always have so much sodium, yes, that I am going to have a sodium concentration gradient. Let's just think about it for a second. I pushed a whole bunch of sodium into the tube, so this is going to be relatively high concentration of sodium. But this cell has been working its little cell butt off to make sure that it's low concentration of sodium, yes? And so now I can bring in glucose, despite what glucose's concentration is, down sodium's electrochemical gradient, right? So I bring glucose in with sodium. What kind of transport protein is that? Carrier. You're my favorite today, Talmadge. That's a carrier because it has to have, A, glucose is big and it needs specific binding sites, right? And then what I am going to do is I am going to move glucose out into the interstitial fluid. This is going to be a carrier too. That's going to be facilitated diffusion, right? Down its concentration gradient, because I never leave it here because it's money, right? And then it's going to diffuse straight into the fenestrated capillary. So that's how we're going to do glucose reabsorption. Of course, we have to take care of the concentration gradient issue with the sodium-potassium pump, right? So secondary active transport is how I reabsorb glucose at the kidney. But this has a shape-specific binding site. So is it subject to saturation? It is. It's subject to saturation. So if, for instance, you got 6 freaking Butterfingers, let's not do Butterfingers. Everybody likes Reese's, or else you're wrong. You got 6 full-size Reese's, and you have siblings. How many do you eat? You eat all 6 of them, right? And you are not diabetic, so you do not die. However, what is going to happen is you're going to have so much glucose in your bloodstream that when you try to reabsorb it, you are going to be limited by the saturation rate of these carriers, and you're going to end up with glucose in your pee. Okay? And then we're going to talk about what that does as it actually goes out. So this is subject to saturation. So if your blood glucose was so high that you couldn't reabsorb it, either because of diabetes or because of Halloween, what is going to happen is the filtrate glucose is high, and this is important for you guys to understand. What is going to happen if the filtrate glucose is high is that if I don't get all the glucose reabsorbed in the proximal convoluted tubule, which is where most glucose reabsorption goes on, then I'm going to be delivering high concentration of glucose through the tube to cause osmosis into the tube, right? Okay, and then I'm going to be delivering high concentration of glucose all the way through this tube, which will pull fluid into the tube. So not only do you have glycosuria, which means sweet pee, you also have polyuria, which means lots of pee, because of the osmotic effect of that high concentration. So let's go all the way back to diabetes again, and one of the first indications that you might have diabetes is what? Is sugar in your urine and lots of urine, right? Lots and lots. And that is directly related to the saturation rate of these carrier proteins that I have for reabsorption in the kidney. Does that make sense? Okay, so it's all kind of this, it's all one class. I'm just telling you. Okay, so that's glycosuria and polyuria. Now, how do you absorb other nutrients? Other nutrients have similar reabsorption mechanisms. Amino acids also get reabsorbed via secondary active transport with sodium. It's a different carrier, but it would be like a sodium amino acid co-transport carrier. Lactic acid and some of your water-soluble vitamins get reabsorbed in a similar mechanism. Cool? But glucose is important. Go ahead.
So do we also want all this sodium back, or is it just a cheaper way than active transport? Like, do we also want, because we're bringing a lot of sodium in.
We definitely want most of that sodium back. Yes. So that actually keeps us from having to work hard on sodium in other places. I mean, we are going to work hard on sodium in other places. We lose so much sodium via filtration that we actually reabsorb almost 99% of it back in. We just use some of it as a transport mechanism for other things. We like piggyback onto it. So are everybody okay with glucose reabsorption? Glucose reabsorption happens how at the kidney? Secondary active transport. Yeah, secondary active transport. And luckily, you already understood secondary active transport, so that was not hard, right? Remember when that was hard? Remember? Way back when? You're like, psh. Okay, so now sodium ion reabsorption. This is a little complicated, so I need you to pay attention to this part because I actually do it in 2 steps, and the second step can be manipulated with hormones. So here's the deal. Sodium is going to be actively, meaning you will pay for it if you have to, and quite often you do, reabsorbed throughout the proximal convoluted tubule and the distal convoluted tubule, but for different reasons, and we'll talk about that. So it's actively reabsorbed by pumps and carrier proteins, most portions of the tubule. Not that much in the loop, but a little bit. But most of the sodium, 65% of your sodium is reabsorbed at the proximal convoluted tubule, and you don't have any control over it, and this is important for you to understand. They call this non-regulated reabsorption, and it happens at the proximal convoluted tubule here, back into the bloodstream. It's non-regulated because you can't change it with paracrine agents or hormones or neurotransmitters. You just always push it all out and then immediately reabsorb 65% of the sodium. Okay? That makes sense? So we used to call that obligatory reabsorption until we figured out that half of our students didn't know what the word obligatory means. They called it obligatory and facultative reabsorption. So now I call it non-regulated and regulated reabsorption, but it's obligatory. Obligatory means you're obligated to do it. So obligatory reabsorption or non-regulated. Okay, so you have no control over that quantity. It's active transport primarily, and it just happens, and you can't really change it. There's some drugs that can mess with it, but you can't really change it with normal physiological processes. But now we get into the next portion, and this is where you kind of have to pay attention. These are going to be hormones that you learned before, but they're going to be impacted. They're going to impact things in a way that you might not expect. Okay, some sodium, up to that 35% that you didn't get before, right? Minus the whatever percentage you used for glucose, right? Close to 35%. So some sodium may be reabsorbed in the DCT if you need it, okay? If I just ate a 1 pound bag of hot Cheetos, I can probably leave it out there, right? But if I've been doing the damn irritating thing where you drink enough water per day, right, you know I'm going to need to. It's so annoying. I don't even know how you people do it. I admire you for your water consumption. So, especially you. You drink tons of water per day, don't you? I don't know. It feels like an extra job. I'm like, I'm already really busy. I don't know how I have time for this. Okay, so some sodium can be reabsorbed in the DCT depending on the body's needs. This is called regulated reabsorption or facultative reabsorption. You'll probably like regulated better. That's fine. So here's my question to you. How is regulated DCT reabsorption controlled? Well, it's primarily controlled by the body's needs, and the body tells its needs by a few different things. There are quite a few stimuli that can trigger an increased reabsorption, so you have to think about this. If you need an increased reabsorption at this distal convoluted tubule, it might mean something about your sodium concentration in your bloodstream, or it could mean something about your blood volume or your blood pressure, right? Or your sodium concentration in your urine. Does that make sense? You could look at all of those things potentially to figure out whether you needed to reabsorb or not reabsorb. So the default is just leave it out there, the 35%. So the major stimuli that could cause an increase in the regulated DCT reabsorption of sodium would be a decrease in blood volumes. Say check if you got that one. If your blood volume is low, you might need to reabsorb some of that 35%. Check? Check. Got it? A decrease in cardiac output. Unrelated to blood volume, but your kidneys would help in the way that they can. Does that make sense? So I'm not saying that your kidneys are directly related to what the heart is doing, but if you have a decrease in cardiac output, your kidneys are a one-trick pony, and what's the trick that they know? Increase blood volume, right? Does that make sense? Okay. So if you had a decrease in cardiac output, your kidneys are like, I got you, bro, but it literally has one solution to that problem. Like it just does, oh, how about I reabsorb? Or it could be a decrease in blood pressure or a decrease in blood flow to the kidney that would trigger it. Or it could be an increase in the sodium concentration of the filtrate. So if you looked at the filtrate and had too much sodium in it in the distal convoluted tubule, you say, I need some more back in. So these are all of the things that you could actually assess. And one of the places that you assess them is, dun, dun, dun. Where is this little bastard? Where are you? The Juxtaglomerular Apparatus. Son of a biscuit, where is it? Did I lose it? Juxtaglomerular Apparatus, which I teach in anatomy every damn semester, and then when I talk about it, people look at me like I've literally never said it before, and I had half of you in anatomy, so I totally know that I did. Okay, so let's look at the Juxtaglomerular Apparatus. Oh, there it is. It was up the whole time. Okay, so the Juxtaglomerular Apparatus is this little physiological tweak thing where in most nephrons, the afferent arteriole runs right by, not connected to, the distal convoluted tubule. Okay, so do you see what's going on here? I've got afferent arteriole, efferent arteriole, and then the distal convoluted tubule just kind of snuggles between them. And so let me give you a big picture understanding before we get into the details, because you'll be able to figure this out. There are cells in the wall of the afferent arterioles that are going to monitor one thing, and there are cells in the wall of the distal convoluted tubule that are going to monitor another thing. So you choose, because you're brilliant, which place, afferent arteriole or distal convoluted tubule, will monitor blood pressure? Afferent arterial, yes. And which place will monitor solute concentration in the urine? Distal convoluted tubule. So what those are going to do is they are going to monitor those things and to figure out whether you need to do anything hormonally to what's going on in the kidney. By mechanisms that you've learned before, we're just putting together a little bit more of the story that we hadn't learned before. So the juxtaglomerular apparatus is going to monitor these stimuli. And one of the things it's going to do is if it's going to respond to, and you know this story already, low stretch in the afferent arterial by releasing renin. Yes? And renin is going to do what renin does. What does renin do to the vessels? Vasoconstriction. And what does renin do to the adrenal cortex? Causes release of something. Causes release of aldosterone. And what did aldosterone do? All the way back to our friend aldosterone. Sodium reabsorption, potassium secretion. So this is blood. This is urine. Okay, so now all we need to do is say, okay, now I can tell you where aldosterone targets. Aldosterone targets the distal convoluted tubule because that's where I can do regulated reabsorption of sodium. Yes, regulated reabsorption of sodium. So angiotensin II, in addition to causing vasoconstriction, causes the adrenal cortex to secrete aldosterone. Aldosterone increases regulated DCT reabsorption of sodium. Water will follow it most of the time. So the net effect, if the afferent arteriole in the juxtaglomerular apparatus is not stretched much, is going to be increased sodium and water reabsorption, increase in blood volume, and a blank in blood pressure. Increase in blood pressure. This is the same story that you already learned with a little bit more anatomical detail. Yeah? So we started the story before by saying that renin is released from the kidneys, but now be very specific about where renin is released from in the kidneys. Where is it released from? Afferent arterial. Yes, it's released from the afferent arterial. Yes. In response to what? Low stretch in the afferent arterial. Yes. And then in addition to its vasoconstriction activities, it also causes aldosterone release. And aldosterone targets the kidneys again, but targets where? Distal convoluted tubule in the kidneys and causes sodium reabsorption. It also causes potassium secretion, but we'll assess that in just a second. Okay, so you got it? Yeah? Okay, so this is the macula densa cells, by the way, and the afferent arterial are going to release this together, FYI, because you can actually be monitoring either the stretch in the afferent arterial or the amount of fluid that's actually in the distal convoluted tubule. And those actually work together as one apparatus to actually release this. So the juxtaglomerular apparatus releases it. It targets, the aldosterone targets the distal convoluted tubule. Everybody okay? Okay. So, and then another hormone that you already knew, again, we're just adding a little bit more detail to the other hormone that you already knew, okay? We're just actually talking about where it actually goes, okay? So we already know ANP. Why is ANP released and where? Prolonged stretching of the atrial wall, right, causes the release of ANP. And we know that ANP targets the kidneys to drop the blood pressure. Let's just add a little detail, okay? So ANP is going to decrease the regulated DCT reabsorption. It's going to target the distal convoluted tubule. It's going to say that 35% that was out there, leave it out there. Don't reabsorb any of it. Yes? Depending on how much ANP you release, but just going extreme there. And it also inhibits the release of aldosterone, right? Does that make sense? And we've learned that before. So it also does one other thing that we didn't talk about before because we didn't have sort of enough information to understand it, but now we do. ANP, in addition to decreasing sodium reabsorption, yes, check, also dilates the afferent arteriole, which will do what to sodium? Increase sodium, use the right word. Filtration, yes. Yes? It will increase sodium filtration and decrease sodium reabsorption, which would do what to your blood pressure? Decrease your blood pressure. Yes? That makes sense? So all we are doing here is adding some detail to the hormones that we already knew. Okay? So one more time. You guys already knew this part. You already knew where A and P was released from. Now tell me specifically 2 places that it targets in the kidney. Afferent arteriole causing dilation and distal convoluted tubule inhibiting reabsorption. Yeah? Does that make sense? And so it drops your blood pressure. Everybody good? Go ahead.
I thought if you, never mind. I'm good.
Got it? Okay. So that's why like this part is like because one of them will do one thing and it is. So the opposite is also true, by the way. High blood pressure would decrease renin, decrease angiotensin, decrease aldosterone, all that kind of stuff is true. Okay. So the last little thing, and then we'll do the think, pair, share, is that note that when sodium is reabsorbed via aldosterone in the distal convoluted tubule, it costs you potassium, right? Potassium secretion. Therefore, elevated aldosterone will, yes, definitely result in an increase in blood pressure and sodium retention, but it can also result in a decrease in potassium concentration. And that's going to be important when we start talking about diuretics, right? Because there are potassium-sparing diuretics. So again, I want you guys to talk with a friend and talk through these, and then we will do it again. Okay, talk to each other, please.
I put B.
Again, if you know the answer, talk through the other ones and why they're incorrect.
So ANP is released from the long stretching of the atrial wall and trying to target the afferent arteriole, causing vasodilation, which is going to decrease filtration. Increase filtration of kidneys. So you're lowering and targets.
Yeah, that's why you have to talk it through.
I'm totally for well. I'm like hard on there instead of like SE it's just like my brain. It's like, oh my gosh, I've never tested in my life.
And then it holds it. So where else? And then targets the distal convoluted tubule to say don't reabsorb sodium. So it's just leaving, it's saying leave that 35% out. And so now you're adding to your urine volume.
D is obviously because you decrease the blood pressure because it's all pressure driven in the glomerular filtration. So if you decrease it, it decreases that.
And vasoconstriction too, you're not allowing filtration, much filtration to occur, so you can't get sodium out.
Yeah, 10 more. Go ahead and answer so that we can talk about it before you guys leave. Seven more people. Oh yeah, you have the hypotension, huh? Orthostatic hypotension. Yeah. So you need lots of water. Yeah. Yeah. Three more people. Get your answer in. 5, 4, 3, 2. There we go. Okay, what is the correct answer, friends? The correct answer is B. Oh, almost all of you guys got it. So, increase the amount of urine produced. Increased ANP would do that. ADH, we haven't talked about specifically, but you do know that it causes water reabsorption, right? Which would decrease. Aldosterone also causes sodium reabsorption, which would decrease the amount of urine produced. Decreased blood pressure in the glomerular capillaries, nobody thought that would do it. Sympathetic vasoconstriction of the renal arteries. Sympathetic vasoconstriction of the renal arteries, remember that was the exception to the rule, right? In which it constricts the afferent and efferent arteriole. So which of these does that impact? Filtration, it decreases filtration. Does that make sense to you guys? Okay, so I'm not going to see you until Tuesday, but the thing about kidneys is that you have to practice using the words and figuring out which direction things go. Did you see that? Okay, all right, so I want you guys to practice before Tuesday. I'll see you Tuesday. If you are deciding to miss class because it's before Thanksgiving, you will probably regret your poor decision-making skills. Because we will finish urinary system and we will start on respiratory system, and they both go really fast. And also, I have to be here.
Ronnie, just look for it, make you like water anymore.
What?
Just look for it, make you like water anymore.
I like it. It's okay. But it's just, bubble water just makes you burpy. Yeah. I like what is it? No, there's a strawberry. No, it's not Pellegrino. It's only at Whole Foods. It's some water that's only at Whole Foods. It's strawberry flavor. So good.
Yeah, because it tastes real. It's called Cinder. You can buy it at Costco, but it tastes like it's like Lacroix. They got in trouble for having pesticides in their water.
Oh, really?
Yeah.